All right, everybody. Well, it's good to see everyone. Happy Monday. Hopefully nobody's blown away yet or anything like that. Dr. Jackson and I were talking about hopefully the internet will stay up while the wind is hitting the house. So we'll see. But if I'm stopped in any weird moment, you know what's going on. So we'll go ahead and do introductions. The first thing, though, I want to do is a little bit of announcements. So we're at our second to last session. We have one more session in the cohort to go. That last session will be around a mock QI project, so a scenario. And what we're going to do is breakout rooms. And so the team from Northwood will be in one breakout room with a couple of people from the team from WVU, and then community care, same thing, breakout room, a couple of people from WVU. And we're going to walk through the same scenario. Each group will do that, take about 10, 15 minutes, then come back together and we'll have kind of a report out and kind of talk about it as a larger group. And it's about, kind of all the kind of stuff we talked about in the recent sessions about, it can be things around who's missing from the team or what's the missing data, what would you do as far as next steps, kind of those kind of questions we're going to ask around this kind of mock scenario around a QI project. And it's really just to kind of take a little inventory of what's happened through the first 5 sessions. And then also be thinking about, kind of after the last session, how to kind of move forward with your projects, move forward with the team from WVU. It's not like we're just going to, end the sessions and never see you guys again. Hopefully we can keep in touch and keep working with you and answer any questions you might have and be around as you need us. So that's what we're going to do for that last session. So one thing we are going to ask, and this is, I guess, more for the community care group, is Dr. Jackson, if you think somebody else like Christy could be there on that last session, so you're not by yourself as we're doing the breakout sessions, that would be helpful. So if you could maybe put that in her ear. I have that down as a recap bullet. You'll see it in the recap email, but if you wouldn't mind just kind of letting her know if she could make it, or somebody from community care, it doesn't have to be her, but she has been on here before. That would be great. So that's the plan. If there's any questions in the meantime about that or after the session or anything, just let me know. But that's how we're going to kind of wrap it up for this cohort. And we'll see what happens. So if you have any suggestions as well, let us know about things we can do. Okay. I think we're set. Everybody's here now. Why don't we do some introductions, real quick introductions. So we'll go around the Hollywood squares here. Why don't we start with Sheena?
Hi, I'm Sheena Sayers. I'm the program manager for the SOAR grant.
Thanks, Sheena. All right, Dr. Jackson.
I'm Benjamin Jackson. I'm a physician at Community Care of West Virginia in Buchanan, West Virginia.
Thank you. Megan.
Hi, I'm Megan Toscano, project coordinator for the SOR grants at WVU.
Thank you. Katie.
Hi, I'm Katie Chasson-Downs, lead clinician for addiction services with BMed in Morgantown.
Awesome. Thanks, Katie. Olivia.
Hi, I'm Olivia. I am in Morgantown and I am doer of all things random and not so random too.
Thanks, Olivia. Let's Josh.
Joshua Witt, clinical therapist or operations case manager at Northwood Health Systems.
Thanks, Josh. Tony.
Hey everybody, Tony DiCiacchio, Associate Dean at the School of Nursing for Practicing Community and FNP practicing with the COAT team in Morgantown.
Thanks, Tony. Let's see, Therese, WVU nurse practitioner student. That is quite the tag. Good for you.
I just wanted to make sure everybody knew who I was.
That is great. Thanks for joining. Tina.
Hi, Tina Harper. I am the Substance Abuse Services Manager for Northwood.
Thanks, Tina. Mark.
Mark Hout from WVU.
Thanks, Mark. Stacy.
Hi, I'm Stacy Wanger, and I'm the Assistant Director for the West Virginia Practice-Based Research Network.
Thanks, Stacy. Mega, are you back? I see you had to leave. She might not be back yet. And we'll have Mega introduce herself in the chat when she's back. But good to see everybody. So today we are going to focus on community care. So we have a couple of different projects from community care. Dr. Jackson, I'll share my screen. You can just kind of walk us through them. Let's just do them one at a time. So just walk through the first one. We'll take a break, have a discussion, and we'll come back to the next one and so on. But I'll turn it over to you though once I share my screen. So just give me 1 second. So go ahead and take it away if you can see that.
Yeah, thank you so much. So this first project is not QI per se, but something I thought I'd mention because it's the first thing we started getting to work on when I started at community care in July. We've been working with the Homer Project now for several months. The Homer Project is a group out of the University of Colorado. It's a multi-site study trying to assess the efficacy of virtual unwitnessed induction of buprenorphine versus in-person induction of buprenorphine versus a witnessed induction of buprenorphine. The reason that I brought it up in the context of this group was because we have a lot of patients that come in and want buprenorphine, and this study is offering to pay them. And even in the context of cash money, we've had one person so far be willing to sign up to be part of what seemed to me a very uninvasive ask, and something that just seemed like upside when I first signed up for it. But that study is ongoing. I think that we will continue to accept patients for the first wing of that study until I think August of this year. So we have a long time to try to get people enrolled in it, but our ability to do so thus far has been very limited. I don't know if it's like an inherent distrust for the system or for scientific endeavors, but maybe people think that if it's too good to be true, it might be. But I've had multiple patients refuse what we were asking, and even in an economically depressed area where there's a pretty good economic reward, we haven't had people really willing to bite on that. Maybe I brought this up because I wanted to know if this is something that has been common for others as sort of just getting my practice started. But I viewed it as almost contingency management to have people that could be retained in our practice and have a financial incentive to do so. So I thought it was completely upside, but it's been really hard to get people enrolled. Does anyone have any questions about that study or any thoughts about what I might be doing differently, or any questions about why I included it in a QI project presentation form?
Really quickly, Dr. Jackson, I will say that we can relate. We have a CTN study going on right now, and looking at sort of different dosages of Suboxone, and previously they were also looking at the injectable form, but that's been on pause. And when we first started recruiting for the study, I thought for sure it was going to be easy to get particularly a sort of particular type of patients who have been in and out of the program and have historically not done well with COAT. The study, besides the fact it pays, they get some money for certain visits and it pays for the medication. They get the medication there, they don't have to go to a pharmacy. It also quickly gets them from weekly to monthly appointments. And so in some respects, it's easier than COAT doesn't have the rules. And I thought for sure we would have a lot of patients go that route. And I have been surprised multiple times where I'm talking with a patient. I'm like trying to spell it out for them. Like, this is going to be much easier than the COAT program because you've struggled with those rules. And they're very much like, no, I came for COAT. I want COAT. I don't want to hear another option. I know you're telling me that those other options are quote unquote easier, but this is what I came for. So I don't know if that's what's going on for you, but I know we've run into that a couple times. Do you mind if I ask what the ask is of the patients for that project? Is it like
they have to complete some phone calls with the study group, and that's about it. And they get
that's
paid
like the
pretty
only
well.
extra thing.
They get
Yeah,
paid
that's
pretty
really
well for it.
interesting.
Yeah, I don't know if maybe it's the way that I'm selling it, and that maybe we need to be trying to pitch this on the initial contact with the patients when they call. You know, frequently we have some walk-ins, but mostly our patients are people that call in to try to establish care or referred to us to establish care. And maybe if the case managers that reached out to those patients to schedule them for intake initially brought this up as something that they could be included in, it would give them time to think about it when they weren't in active withdrawal. I feel like that may be the main thing that I'm missing, is that people just want their medicine and they want to be left alone as far as right this minute. And if I could ask them 12 hours before I was asking them, or 12 hours after, I'd probably get a much different answer. And so maybe it's trying to figure out how to get the ideas of this study in their head beforehand. And I'm going to try to do that moving forward. I still have several months, and we get a lot of intakes, so I'm hopeful that we'll be able to help the study. I think we've already enrolled more than a lot of the sites in the study just with our one patient. But yeah, anyone else have any questions about that, or anything I neglected about it or any wisdom for me? I really appreciate it, Katie.
So the thing that I would say is, to me, what you're describing is a QI project. I mean, you have a particular problem, you're having trouble enrolling people. And so you've kind of stopped and looked at, so what's the roadblock? What's the problem? Increasing enrollment. You have an idea, you're going to implement it, and you're going to see if it changes the outcome. So that could be a research study, that could be getting people to show up at their second appointment. It can get, whatever it is, you can look at it from that same framework. And, in doing that, I would be thoughtful about getting other people's perspectives about what you're going to try, see what they think, and then trying to focus in and not change too much at once, so you'll know the outcome. It's like starting or changing doses on 3 different medicines at once, and they have problems. You have no idea what is causing what. And so taking a little bit of that approach would be important. From somebody who's done research for a long time now, the thing I always think about is, whenever you're enrolling participants in a study, even if it seems like a win for them and the ask is minimal, you're more likely to get people to do that if they know you, trust you, and then will more likely follow what you say. If they really don't know you yet, if they don't know much about you and your program and your approach, they're going to be hesitant about everything. You're right. They're just going to want their medicine and get me out of here. But, if they have some reason to have trust and faith in you, then it's not only anything you ask about treatment that they're willing to consider, but it's participation in a research project. When I look at the projects I've done over the years, the projects that I do with patients that I have direct contact with, I don't have problems enrolling them in my studies because they know me, they trust me, and it just happens. If I got to go to somebody else who doesn't really know or understand what I'm doing, I can count on that project canning, because they just don't know it. They can't explain it. They don't know who I am. Why would I be in this? And so a part of that is making sure they got that background and understanding about you and trust in you, I think.
I mean, I think that really nails it. I just don't know where that leaves me. Because it's, we're talking about induction. So it's like, I tend to gain rapport with these folks and trust with them pretty quickly, but I'm not cold calling people selling it. It's not, I don't have it. I don't think I come off very well on the phone would be my guess.
Dr. Jackson, do you have a referral source, like from a community clinic or some other, primary care?
Yeah.
Be the upstream area where they already may have trust and you could partner. I know when I worked in primary care, I did that before I entered the university. I would recruit my patients for their studies. And do you have relationships with anybody?
I mean, that's a good thought. Like we're part of a large federally qualified health clinic. So yeah, a lot of my referrals are coming from primary care providers in my group. So maybe I need to pitch it to the people that are sending me referrals. Now we get a lot of referrals from like experts and yeah, it's certainly food for thought. So maybe that's the step that I need to take with it, is to try to have the study addressed by people upstream of me. I feel like a lot of my patients just almost cold call as well. That I'm using that term a lot, but they just heard that there's a facility in town and reach out, and many of them don't already have providers if they're trying to get established on medicine. But yeah, that would be something I could do. I feel like the initial thing that I'll do is to try to have a meeting with my case managers and describe to them the hurdles that I'm experiencing with getting people enrolled in this study, and see what their feedback is, and see how we can better maybe try to be more proactive about pitching this before they're in withdrawal, or when they're first coming to see us, and see what kind of headway we might be able to make. But Dr. Hout, when he talked about not having much success with people that you don't have trust with, I think that's a big crux of the issue. Is these people are when they first arrive, they have no reason to trust me, and they're usually in withdrawal. So it's a double whammy.
Those patients that you're so sorry, Dr. Jackson, those patients that you're in touch with now, that you're still working with, I wonder if you could also ask them for feedback and say, when you said no to the study, what was that about? Was there just no chance in hell you were going to say yes on that day because you were sort of, your brain was somewhere else? If I had called you ahead of time, or is there a different way I could have presented to you? They may give you that feedback. Yeah,
but we could have them fill out like a post refusal survey once they are stabilized on medicine. That would be very brief. Yeah, that's something that I could definitely do. Excellent. Thank you for all the suggestions. It's going to be very helpful to me moving forward, and to trying to get all my patients money, which you would think they would want.
How dare you try to help them out?
I mean, and I'm not sure if they gave you any kind of like information, pamphlet, flyers or things, but I'm always a big fan of something tangible that they can take with them. I'm just a big.
We do have some paperwork but I think that may be another part of the problem, is that we go through such a litany of paperwork on intake that handed them another thing to look at.
Well, I mean, with
just a brochure.
Yeah, or even just a simple flyer that like gets their interest piqued about it, so that they can get more information. Or like if you go and partner with the primary care, you can give that flyer to them to give to their patients to give them more information about it.
Sure. Well, thank you all for the feedback. I will try to come up with a project after talking to my case managers and see if we can get more people enrolled in that study, and see what kind of intervention we want to have moving forward. I think my gut is that we're going to try to reach out about the study with as minimal verbiage as possible during the whatever kind of communication we have with them to schedule their intake appointment with us. I think that's probably where we'll start. But I'm going to talk to the team and see what their thoughts are. But thank you so much. That was all super helpful.
Okay, let me pull up the second one here for you. Okay.
The second project that we have that's somewhat underway that we haven't really collected any data for, because I know the exact data off the top of my head, is to try to retain more of the dismissed patients from pain management. We have a pain clinic through Community Care West Virginia that is in West Milford, West Virginia, which I think is outside of Clarksburg, and they have a practice where they dismiss a reasonable number of patients for frequently opioid use disorder, sometimes cannabinoid use disorder, sometimes methamphetamine use disorder. And I'd really like to try to retain those patients. I have exactly one of them. We have probably about 200 patients all told in my practice. And I think about 80 or 90 of those are buprenorphine patients. I think that all of these patients that are being dismissed from our pain clinic are being done so in a very impersonal manner. I think that their service does not want to have confrontation in their clinic and frequently sends these people a letter, which for a lot of reasons I don't think is great. But certainly if these are people that are suffering from opioid use disorder, they can be offered treatment. And trying to work with the PA that I work with, Tracy Sherman, who's somebody that actually came to my clinic from that pain management clinic. So he has a lot of relationships already with those providers about maybe working there half a day a week or half a day every other week, or in some context like that, to try to do warm dismissals, if you will. Now, this idea has been met with some pushback by the pain team, because they really, I don't think, like the idea of having a possibly hostile just time of their day where people would be getting dismissed from pain prescription. Obviously, I don't prescribe any kind of buprenorphine product. I don't prescribe really any kind of product other than NSAIDs and Tylenol for pain. But frequently I think these people have opioid use disorder, and that's why they're leaving the pain clinic. The one patient so far that I've had from their service is a patient who came to me in, I told him that I would have him involuntarily, that I would be calling the judge based on his level of distress if he didn't present to inpatient treatment. And he came back the next week, and ever since that time has been extremely compliant and extremely emotionally appropriate and extremely well controlled from an opioid use disorder standpoint on buprenorphine. I think there's a role for us to try to retain some more of those patients that may be getting dismissed because they're misusing medication, when in fact we might be able to provide them treatment for their underlying disease. And if their pain is helped at the same time, that all the better for it. So far, like I said, we're at a point where we have some pushback from, I think, the pain management team, but I think that as we work through this, it'll be that will be alleviated by the desires of the administration to not just kick the patients to the curb if they're opioid use disorder patients, but actually try to retain them within the practice and try to treat them for opioid use disorder if they would like to be considered for such a service. My data point right now is exactly one. So that's easy math. And the intervention.
Dr.
that we're
Howell.
trying- oh, sorry.
Nope. Go ahead, Dr. Jackson. Sorry.
No, I just said the intervention that I'm trying to perform in this case is to have my PA probably work in that clinic, at least a half day a month, and try to do warm dismissals, as it were, for patients that they either deem appropriate or for our service or otherwise. Right now, I think frequently those patients are dismissed in a pretty not in-person way. I think they're getting letters stating that they're not going to be receiving medication from the pain team any longer. And I think that there's a much better way to do that, and that's what we're trying to accomplish.
Do you know anything about our pain program up here?
Yeah, I rotated in it. I've probably tried to send people to it. They don't do interventional treatment at our pain clinic at Community Care, but we send people for interventional treatments to UHC down here. They're frequently their spine center if we think they'd be a good candidate for injections. I really love my time at the pain clinic there, and I just like all the providers. Certainly working with Dr. Hirschler was a great blessing for me, but also the interventionalists, I think, perspective on the disease that we deal with, that I deal with much more often, was also eye-opening to me. It also taught me that I need to be pushing really hard on gabapentinoids. That's something that I'm currently, I'm fighting the good fight down where I'm at. And I think that I've won in that I think in my entire FQHC is going to stop prescribing gabapentinoids from primary care doctors, at least for the most part. We have a big issue. We have clinics in Marlinton and in Clay. These people are far from literally everything. There's APPs that I'll message sometimes, PAs or NPs that'll be managing someone's antipsychotics, and I'll be like, do you think we could manage this a little differently? And they'll be like, please, will you do it? Like, and similar with the gabapentin, I think, is that if you're 4 hours from the nearest pain clinic on roads that, are borderline roads at best, and you don't have a job and you've been collecting this, that's a pretty common story where I'm at. So I try to be kind with the providers as well, but I'm in a place where I feel like buprenorphine and gabapentinoids are an absolute contraindication. And my hope is to get, that's part of my motivation behind this pain clinic scam that I'm currently running, is that if I can retain some of these pain clinic patients, then hopefully we can have a detente as far as gabapentinoids and buprenorphine, and I could segregate all of my gabapentinoid patients that might be appropriate to be managed on gabapentinoids to similar to the way WVU does it, but it's hard to send people to Suncrest from Clay.
Yeah.
Even Buchanan is a haul.
I was asking if you had a chance to kind of learn about kind of the orientation and approach, because what it sounds like to me is you're trying to slowly build a piece of that with your patients. Because, the thing you're trying to do is, if you got people who have a particular problem, rather than just dismiss them, you want to funnel them differently. And so, putting did you say a PA in the clinic half a day, whatever, and, and their goal when they first go in there is just not to piss anybody off, whether it's the providers or the patients, and just kind of, find their way and then offer a little bit of help and build that. And to me, that sounds like a perfect approach, because you don't change providers' orientations about stuff like this. If they're hard about that, you don't change that overnight, that. But you have somebody in there, and the first time that they help somebody and take a load off the providers at the same time, that's going to be a win, you know? And so it sounds like that's exactly what you're trying to do, and set that up to make a change with that. And you're not going to change it overnight, but you know that. And you got a nice approach to it. I'm all for that.
Yeah, I totally echo Mark's comments. And I really see that long-term helping change the culture down there, that it's not about just dismissing those patients from the one clinic. It's about them being referred to a higher level of care because they've shown that that's what they need and that's what you're going to offer. By the way, I had to Google what detente was. So thanks for teaching me what detente meant. Appreciate the lesson.
We could use some of that overseas right now.
Yeah, maybe. It's a good word in the context of what I feel like I don't want to push or pull too hard. Sorry that it was, you know.
What a
No,
segue.
I mean, that makes
What a
perfect
segue.
sense. I
It.
like
Perfect.
what you're doing, and I think that that's absolutely the right approach.
Thank
with
you.
that.
Does anybody else have anything on my pain attack? The last project that I'm working on is, I think that I'm going to start measuring the patients that I receive from drug court and whether or not they fill out a CFR with us. And I may do it not just for drug court patients. A CFR 42 is a form that we are required to have to be able to communicate with their case worker through the court system, or their parole officer, or whatever that person's role might be. We have a relationship with a lot of the people in the legal system. And I'd like to try to make that better. I'd also like to try to find out, you know, a lot of the patients come to me very skeptical about whether or not they're probably rightly paranoid, but I'd like to find out if there's a communication strategy that I should recommend to the patients that I attain through the legal system, whether I should advise them that infinite communication is wisest, or whether I should advise them that it's none of their parole officer's business what they do in my clinic. Because right now I don't have an answer to that, and I think the best way to answer that would be data. My hope is to start, you know, a project where if I think there's 4 conditions as far as I can tell. Or 3 anyway. There's a condition when somebody presents that they want to have me be able to communicate with their parole officer. There's a condition when they present and they don't want me to communicate with their parole officer. And then I guess either of those conditions could switch to the other one, making 4 total. I'd like to track their outcomes from a retention in my program status, because I think if they're retained in my program, then they didn't go back to being incarcerated, which I think is their goal, and it's drug court's goal, and it's you know, certainly wouldn't be a terrible goal for my practice either for those patients. So I guess that's it in broad strokes. We've started this really in the formative and planning stages at best. Certainly there's a lot of people listed as far as who's on the project team. Many of those listed are peers that work very closely with the legal system, the parole officers, the drug court players, the judges in general. And so I think that their feedback is essential. At some point, I'm going to have a meeting with these folks and pitch this plan to them. For the time being, I'm basically recommending that people allow us freely to communicate with their drug court supervisor, their parole officer. I'm sorry that I don't know the name better. I'm always looking for language that's not stigmatizing. And I've never found something I've never found a term for institutionalized. If anyone can come up with a non-stigmatizing term for institutionalized, I'm in the market. Everything else I'm pretty good on. But for the time being, I recommend that these patients do fill out CFRs with us so that we can communicate with their legal team. And I think I probably have a less than 50% success rate in that. Most of these people are very suspicious that any communication would take place between myself and their legal team, even if it's the case where I don't want to make an accident and put them on a medicine that they're not allowed to have or that's frowned upon by their caseworker in the legal system. Does that make sense? Was that pretty well stated? Does anybody do you guys have any thoughts on those 4 conditions that I mentioned? So people that present and want communication, people that present and don't want communication, and then people that switch, because that does happen. It's happened to me several times so far.
Yeah, you were talking, Dr. Jackson, this is another great project for so many different reasons. You were talking about the things that you could track or potentially track. What I would find fascinating is if you also tracked who their probation officers are or drug court judges are, and I'd be really interested to see if there's any connection with the outcomes for that based on the team that we're working with, because that's been my experience. Some of the, depending on what county they're in, some of the folks on those drug court treatment teams are really understanding and really respect okay, you're going to tell me what I need to know, but you're not going to tell me everything. And some are very much on the, no, you absolutely have to tell me every little thing. And so there's variability. Not only do you have to deal with the patient's variability in what they're willing to give away, but then there's going to be variability in the requirements from their team. So that's just, that's not helpful at all. I'm just telling you, yes, this is a delicate situation.
It's helpful.
Yeah.
It's more delicate in other counties than where I'm at. Upshire's not that bad. Randolph's pretty good. I always get Taylor confused with what's the county where
Tucker,
where Philippi is. Barber's similar to Randolph in my experience. Randolph and Barber have been pretty good. Upshire is pretty good, but it's not as good as Randolph and Upshire, or Randolph and Barber. Lewis is pretty similar to Upshire, and then I try to drive around not Gilmer County. What county is it just south of there? Where's Sutton at? That county, Braxton County. There's that county. I'm scared of everybody in that county. Oh boy. I got subpoenaed down. We've gotten subpoenaed a couple of times recently by them.
We've had really good luck we've now had 2 rounds. Is this right, Tony and Jay? We've had 2 rounds of, I don't know what the title of it's called, Judiciary Echo, is that right?
Yeah.
Where we met with judges throughout the state, and I think there were a couple of probation officers on the call. And so working with them on, sort of partly providing education on MAT, but also getting some education from them on how that system works, and basically how can we just work together for the positive outcome of the patient. It's been really fun to participate in. I don't know if there's a future opportunity for that.
Yeah, I'm not sure if there's going to be a third one, but I would say, Dr. Jackson, I think there's somewhere to meet in the middle, because they're just as, trying to figure out how to connect the dots as much as you are, because there's so much that goes in between them seeing them, the judges, and then, what happens with you. And so I think everybody's, hopefully going to work to that common goal. But I agree with Katie. I think, knowing who's better at it than others might not be a bad idea, if you can, but, because I think
it's not like there's enough people that it would be challenging to attain to track that data as well. I mean, we're talking about probably less than 10 people that I would deal with as part of this. So I mean, I feel like there's no reason not to look at that, to have that data as well. I guess I don't want it to be a confounding variable is what I'm saying, but might as well have it.
As long as they're not from Braxton, huh?
I mean, I have no problem with the people of Braxton. I have some great patients that are doing wonderfully from Braxton. It's just their court system is it's their judge scares me, man. I do my best. I want to work with everybody, but you know, I hop too when I'm paged to Sutton.
Katie and Tony need to comment on this, but I got the sense from the judges we worked with, a lot of them felt like scared almost, like they didn't want to make the wrong decision once they figured out kind of like what the situation was. That's how they came off to us, at least, was very much, you know, like, I'm not against anything. I just don't want to screw it up. So then it's all over again. We got to do everything over again. That's kind of the sense I got when we started talking about a lot of the logistics and things like that.
Totally echo those comments, Jay. Yeah, that I think they wanted to figure out what was going to be best treatment wise for the patient and how could they in their system either support or potentially interrupt that. So very good point.
Can't speak for the Braxton guy, but, or woman, I don't know, but the other people, I think
Both actually.
they were more amenable.
No, I mean, I would love to work with the folks in Braxton as well. And we have some relationships with them through providers that have worked down there with their drug court pretty closely. I guess I have more hope for sort of outreach to the community that I'm in now, which is Upshur. And then, like I said, Randolph and Barber counties, I think are pretty pro-treatment is my assessment of their courts. I get their patients a lot, like sort of required to see me and required to do therapy through us. And it not be like a big hurdle for them. Whereas in Braxton, I've had a number of issues where their treatment through my service was almost being held against them. But that's all I was referring to. I'm just joking. But yeah, I think it's a good opportunity for a project where, you know, I could learn some valuable information about, and I could take that information probably to those relationships that I've made in the legal community there, to try to get them to understand where we were coming from a scientific place. Be good, you know, more data is good. So that's the stuff I'm working on. And then always trying to hire employees in the market.
Thanks, Dr. Jackson. Those were great.
Thank you.
We appreciate you taking the time to do that. Any other comments? Mark, I saw you unmute. Did you have a comment?
Yeah, a couple things real quick. One is, you know, when I hear you describing this latest project, you know, the thing I think about is what somebody told me once, which is if you have a clinical skill, don't take your clinical hat off in those kind of situations. You know, you have an ability to understand people, you know, to build trust and relationships, to work with your patients. It's the same kind of thing with judges, probation officers. If they're pissed and angry, they're pissed and angry maybe because they don't want to do the wrong thing or because they don't understand. And, you know, if you can see their perspective, your chances for change go way up, you know. That said, you know, I try not to psychoanalyze people all the time or I'd go nuts. But, you know, when you're in a situation where you're struggling, don't take your hat off. And then the other thing is you got a lot going on. You're doing a lot of good work. And so I don't want you to put your brakes on, but in some sense, I want you to try to, of those 3 things that you presented to us, I want you to think about which one you're really invested in doing from a QI standpoint. You're going to do all that stuff anyway, you know, but from a QI standpoint, I would focus on one project. And you're going to do that to learn the process of how you do QI so that you can then use it later on. So it doesn't matter to me which project it is, because you're going to do them all in some sense and way, but pick the one that you can learn the most from in getting that process. So the next time around, when you're really ready to go with QI and you have something specifically, you've gained that knowledge to do that. So do everything you need to do, but pick one as a QI focus to test out these methods.
Thank you. I appreciate that. I think that the pain project is where my Q energy is focused right now. I just threw the other 2 together to overwhelm you with things. Also, as far as the keeping your clinical hat on, I shaved because I was under the impression that I was going to have a meeting with the judges soon. So, and I dressed for them. I got cowboy boots. So this is for the judges.
So I remember once I had to go to court in Pineville. Did I say that right? Pineville? Had to go to court in Pineville. And my neighbor, Dr. Covey, said, Mark, drive your Jeep down there. You leave your BMW at home. He goes, you ain't going to make any friends pulling in there in that BMW. Drive your Jeep. And I said, but I want to drive that BMW on those switchbacks. He goes, go back another time and do that.
Words of wisdom.
Yeah, I was gonna say new vocab words, how to dress appropriately for these guys. Yeah, I mean, what a session, for sure. That is great. Any other comments, Tina, Josh? Anything to add? Going on? Anything else going on? Anything that you would like to comment? It doesn't have to necessarily be about the cases, but anything else. Okay.
I just had one thing.
Yeah.
We work very closely with the courts up here. We have First Circuit, Second Circuit, Family Treatment Court, Federal Drug Court, all of those things in congruence. Federal Drug Court, they're not a big fan of MAT, but as other it really, I like the way Dr. Howe put it, is keeping your clinical hat on, because I think that's how we've developed such good rapport with the court systems in this area. I am one of the liaisons that go to our First Circuit drug courts, and the reason they are able to continue on Suboxone MAT is because they're getting services through us, which is monitored very closely. So I send out reports every week regarding their compliance and what have you. Then we have treatment team meetings, and the problem up here is, which I'm sure it's all over the state, is if somebody gets sanctioned, it's very, very difficult to now send them to do, an overnight or a weekend stay incarcerated, because likely they'll come back out with something else in their system than they went in with the first place. So we run into that a lot. We've run into issues, this isn't MAT related, but if we have, I guess it kind of is, if we have somebody that isn't on buprenorphine or what have you, and then they go into jail for their sanction, their 30-day sanction or whatever, and they come back out and test positive for buprenorphine, then the courts all of a sudden are just completely against it, because they say they're abusing it in the jail. So then they're like, why would we prescribe you something that you're already abusing? So it's kind of a conflict there, and that's when it gets tough, whenever there's 0 degrees of separation between the jails and the outside, unfortunately. But develop, and when it comes to judges too, Judge Sims in particular, he's probably one of my favorite people ever. He's very MAT friendly. He's not even just MAT friendly, he's client friendly. He wants the best for all of the clients. Judge Cuomo is the same way. He's just a little bit hard-headed when it comes to that. He's not really, he's okay with it, obviously, as long as it's working. As long as it's working and it's helping the client, they're all okay with it. But the problem that we seem to run into is with people that want to get on MAT, because they had abused it or used it, incarcerated, they don't even let that be an option to be considered whenever they get released.
Thanks, Josh. That's helpful. Yeah, I mean, that kind of makes sense. I can see that happening. Yeah, unfortunately. Okay, if there aren't any other comments, we will adjourn. We will be 2 weeks from our last session, and like I said, it'll be that mock. We'll have more information come out to that for that prior to the session, but that's how we'll close out the cohort.